Our speaker tonight is Nadia Borlase, who is probably one of the younger presenters in the What If Wednesday series. She is still undertaking her research for her PhD in the Department of Psychology. She works actually in what used to be called the Van der Veer Institute, but is now called the New Zealand Brain Research Institute. And that's a place with which the Department of Psychology has a long-standing and extraordinarily valued and valuable collaboration. We've had now, right since the founding of the Institute, a history of participation by academic staff, particularly Professor John Dalrymple-Alford, and various graduate students in the work that's done in the Brain Research Institute. And what you're going to hear about tonight is particularly cutting-edge research that has come out of that collaboration. Nadia has been supported in her research by a number of sources of funding. She's had a Todd Foundation Award for Excellence. She's had the Ray Newton Scholarship, which is awarded by the Canterbury Medical Research Foundation. And she's had support from the New Zealand Federation of Graduate Women. And she's also had support from the Neurological Foundation. And all of those sources of support are very gratefully acknowledged, because without them it would be difficult for us to do research and to support students in the work that they do. Tonight she's going to talk about what if we could predict dementia in Parkinson's disease. So Nadia, it's all over to you.
Thank you very much. Okay, so as Neville said, I'm a PhD student. I'm not that young, had a birthday yesterday, so just pretend I'm a little bit older. Based in town at the New Zealand Brain Research Institute, which is an amazing source of resources for all of us, and we're really lucky to have it. And obviously, without our patients, we would be nothing, so I'd like to just gratefully acknowledge the countless hours that our patients give us, and also the countless hours that their support people or their wives or husbands or other family members give us as well. But tonight we are going to focus on the predictive ability of finding dementia in Parkinson's disease. So I've spent the last 4 years hanging out with 100 patients. They're all lovely people. Some of them bring me flowers, chocolate, it's lovely. So the whole point was to try and figure out what changes are occurring in their brains and to see if we could use this information as a useful prediction to dementia. So our initial results, which I'll go through, are quite promising. We're the first ones to find what we've found in this disorder, and we're actually the first ones to find it in any neurodegenerative disorder at all. And so our aim is, in the long term, that we'll be able to identify people who are most at need of intervention and be able to give them the treatment that they need well before dementia develops. So what I'm going to do tonight is give you some information surrounding Parkinson's disease, the implications that this has for New Zealand, being that we're a tiny little country in the middle of the ocean, and being that we've got the baby boomer population that have recently started retiring, and that brings a whole lot of complications with it as well, of course. I'm going to briefly talk about dementia in Parkinson's disease. I'm going to explain what I do and how I do it, and most importantly, why I'm doing it. I want to go through how this is actually supposed to help people, and if it actually does help. So first, just to get things kicking off, I'm going to tell you a story. This is a fictional story. The characteristics are of one of our patients, but for confidentiality reasons, we're just going to call him Mr. T. Rimmer. So, he's a 57-year-old male, worked hard his entire life. That's him there in the blue with his wife, his lovely wife, and his small child. So he was basically a boring, a typical Kiwi man. He never went to the doctor, never had any problems, never really complained about anything. And then one day when he was sitting down after dinner, he noticed that his right hand started shaking. He kind of looked at it, and being a man, he was like, "Ugh, just tired, just stressed, it's fine." And then when he started getting up from his chair sometimes in the evening, he noticed that his legs started feeling a little bit stiffer than they normally would. And then his arms started feeling a little bit stiff. And then one night in bed, he was complaining to his wife that he felt like he'd been working hard out on the farm all day. And she said, "But darling, you've been working in an office for the last 20 years. You shouldn't be feeling like this." So when he started having trouble with his fingers buttoning up his shirt, he finally went to the GP. And the GP said, "Oh, I don't think you're just getting a bit old, Mr. T. Rimmer. I think you've actually got Parkinson's disease." So then he ended up in our clinic and has been in our study ever since. He's still doing completely fine. He's had the disease for 4 or 5 years now and is still happy as. So that's ideal. So the prevalence of Parkinson's disease isn't actually that bad. It's less than 1% of the population in the developed world. So if New Zealand's population is almost 4.5 million, that's 355,696 estimated people with Parkinson's disease. The vast majority of them end up in our clinic, which is really helpful for us, but there doesn't seem to be any sort of relationship between where you live in the country or what your socio-economic status is or your marital status or even really your ethnicity. So it's one of those disorders that just sort of appears for no apparent reason at all. Unfortunately, with the ageing population, by 2030, the prevalence of Parkinson's disease is expected to double in all developed countries, which means us and the big players like America and Europe as well. So, for New Zealand, because Parkinson's disease is an age-related disorder, and because we have the baby boomers to think about, this means it's actually quite a big concern for us. So if each little pin on this diagram represents 100,000 people, the red pins are New Zealand's total population. The green pins is the 2012 baby boomers. So how many people right now are at retirement age? So 611,000 of them, 13.8% of the population. In 2036, we're going to lose more of our little red pins and get more green pins, and our baby boomers at retirement age are projected to increase to 1.2 million. So then, in the baby boomer age category, we're going to have 1.5 million by 2061. Now, if we think about this logically and we think about the prevalence of Parkinson's disease doubling, that's 240,000 people with Parkinson's disease in our tiny little country. Our clinic's not actually that big, so we need to start dealing with this now. So let's just have a little discussion about what Parkinson's disease is and the relationship that it has with dementia. So obviously the motor symptoms of Parkinson's are the most visible. If we think about Michael J. Fox as an example, he's had Parkinson's for years, and it started in one of his hands. And apparently, those that are in the know, if you look at his later video recordings, he's always got his left hand in his pocket, and that was even when he was in his 30s, because that's how early the symptoms presented for him. Not everybody's like that. We've got patients that their tremor doesn't present until way later, and they're in their 60s before they notice that anything's wrong. Some of them are in their 70s. But then we also have the early onset. We've got a woman that was diagnosed at 51 with Parkinson's as well, and she didn't have a tremor. Her symptoms were completely different. So not everyone's the same, but on average the motor symptoms, especially the tremor, will be the first one that people will see. Dementia onset, though, is, in my opinion, even a worse symptom to have. So dementia causes the most problems for families. It causes the caregivers, the wives and the children and the wider extended family the most stress. And unfortunately, it's also the biggest cost factor. Now, this isn't because of useful things like treatment options or anything like that. This is unfortunately due to the 24-hour, 7-day-a-week care that's required once patients get dementia. For a lot of families, this isn't what they want, and it's a horrible thing to have to do to get someone else in to care for someone that you've loved for so long. But unfortunately, it is a necessity due to the danger that they'll present to themselves and to other people around them. Our dementia patients are quite good at wandering off. When we leave them sitting in the reception area, you can quite often come back and they would have disappeared if they've not got anyone with them. And so, obviously, waking up in the middle of the night and finding your husband or wife has gone walkabout is not a very pleasant experience for anyone. So, the prevalence of dementia and Parkinson's disease varies widely depending on who's doing the study and who they've measured. Some estimates are as high as 80% and some are as low as 30%. So not everybody will get dementia. Anyone with Parkinson's disease doesn't even have a 50% chance on average of getting dementia. It is the greatest predictor of nursing home admission, however, and that's just because of the care level that's required. So, this is where things get really good, and I tell you I actually can't help you at all. There's no cure for Parkinson's disease. Our treatment options are quite good to control the motor symptoms though. So patients can take a course of dopamine replacement therapy, which helps control their tremor and helps control their stiffness, and it helps get them moving again when they get stuck in their chairs, so that's really good. There's no cure for dementia either. So obviously we're working quite hard on this, but we're not quite there yet. There is evidence in Alzheimer's disease to suggest that drug intervention will help control the worst of dementia. So a whole pile of patients in the early stage of Alzheimer's and in the late stage of Alzheimer's have been trialled on this new drug with varying results. Most of the patients themselves report that they feel better, and most of their families will report that they're coping better with daily tasks, and whereas before they'd forget to brush their teeth, they're now remembering to brush their teeth in the morning. So just little things like that we all take for granted, but it can make a massive difference to the family that's having to deal with this. The research did show that the earlier the patients can get this drug treatment, the better it will be. And ideally, they want to give the drug treatment before the symptoms are even visible. This obviously presents a whole lot of problems, and that's what the National Dementia Strategy for New Zealand, which appeared in May of 2010, sort of recognised. It's a whole giant boring report, but basically it says that it's important to recognise dementia in the early stages instead of spending heaps of money waiting for people to get dementia and then helping them. It's much more important to identify them as early as possible and treat them as early as possible for the best outcome. And this is much more cost effective as well, so everyone wants to do this, even the government. So because Parkinson's disease and dementia are both brain disorders and related to the changes that happen in your brain, the best way to see this is medical imaging. We've used a couple of different types of imaging. I'm not going to bore you with the details, but it's basically cutting-edge research and quite exciting. The Brain Research Institute where we are has a big, powerful scanner. It's the most powerful one in the country, and it was also the first one to be used, to be installed and used here 2008 or 9 or something. So we're really, really lucky to have it, and unfortunately it doesn't fund itself, so we're even more lucky to get it. But basically, what a whole pile of people have done has shown what happens in the brain once you've got dementia. And we were like, oh yeah, that's nice, but it's not that helpful for what we want to do. So what we've done is we want to try and see what happens in our Parkinson's patients before they get dementia. I guess the idea is to try and figure out the progression of the disease, and then in 20 years' time when we can actually give drug intervention, old Joe Bloggs could come in and be like, oh, I think I've got Parkinson's disease. we could scan them and figure out where they are in their progression line, and then treatment options will be able to be targeted to them much better than if we just sort of didn't really know where they were, how advanced they were, or what was happening. So this is where we are. This is our nice pretty building. Summer day, doesn't happen very often anymore. We are focusing on Parkinson's patients. Even though we have a myriad of Alzheimer's patients at our disposal, we're focusing on Parkinson's because these patients transition to dementia fastest, and they are in the highest risk category to develop dementia. But in saying that, not all patients will get dementia. We've got plenty of patients that have had the disease for more than 10 years who are completely still cognitively fine. Michael J. Fox doesn't have dementia, and he's had Parkinson's since I was a child, so forever, basically. So although they are in a higher risk category, and we are focusing on them to try and help with this, not all of them will get dementia, and that's what we're trying to figure out. What brain changes are there that make someone get dementia versus someone that doesn't? So in line with that, I promise there's only like 2 boring graphs I'm going to show you. If we just pretend that each of these little blobs is a measure on a memory test, or a test of behaviour control, or a test of interpreting visual stimuli. And so these people here in this wee group, these are normal people. They're still a little bit old though, but they are normal old people. They don't have Parkinson's disease. And then these people here, they have Parkinson's disease, but they don't really have any memory problems yet, and they don't have any problems planning, or they live their normal lives and they're not worried about it at all. This line is average function. Once you get to the mid stage of cognitive impairment, which is when you're having some trouble with your memory, you may be having some trouble with behaviour control, perhaps you're having some trouble looking and interpreting things that you see, but not necessarily all of those things. Quite often a patient will just have trouble with one of those things, and we refer to that as mild cognitive impairment. So just in the middle stage of impaired. So they, you can see here, are functioning below average, but they're still nowhere near as bad as these Parkinson's disease with dementia patients. Now this all looks nice and pretty on this little graph. There's a nice little line there that indicates that you can start at the top with your Parkinson's and end up way down here at the bottom. But, as with all science, that's not necessarily true for every single person. So if all the little dots are each of my individual patients, you can see that some of them in the mid-stage are still completely fine. They're performing well above average on multiple tests. And then even some of our dementia patients are only slightly below average. So although the cluster is kind of in here, the average of the group is quite low, there are still all these people that are well above that or well below that. And that's just how science works, unfortunately. It looks good on a graph until you do something like this. So what we have done is taken all these images of our patients and our normal people, and we've done this using magnetic resonance imaging, or MRI, which is basically just like a big complicated powerful X-ray. So we lie the patient down, smush them into the scanner, and they're quite happy to do it, even though we tell them all with their Parkinson's disease to lie still please, try not to move. Can you stop shaking? No, just lie still. It's amazing that they do it. They're like, okay, I can do this, I can lie here for an hour, it's all in the name of science. They're lovely people. So what we get after tormenting them for an hour is we get a picture that looks something like this. So if this is a person's nose, I'm facing this way, that's my nose, and that's the middle of my brain. Down here is the spine and the rest of the body. And then for this one, we just pretend that you've just made a huge chop right in front of the ear, and we're looking straight in this way. So it's all a nice little picture. There's some grey bits, there's some black bits, but what does it really all mean? We can't tell just by looking at it what's going on. But it is interesting to note that with our normal people, their brains fill in all this space right around here. And then with our Parkinson's people, this is what we call atrophy. So there's a few gaps there just because the brain is kind of shrinking in response to the disease. And this doesn't happen for everyone either. Some people don't have any gaps at all and they've had Parkinson's for 20 years. But on average, there will be some small changes like this in the brain. But you might want to know why all this ridiculousness even occurs. And the reason is because we get major cell loss. And that's what happens in Parkinson's disease. We don't know why it starts or anything else about how it even gets there or how it begins, but we do know exactly what happens once it has started. So the cell loss will always begin down here in the brainstem. And the brainstem controls movement, and that's why the first symptom of Parkinson's is always a movement problem. That's why it'll be a tremor, or it'll be a joint problem, or it'll be trouble getting up. And that's because there's cell loss happening in the brainstem. And then the disease progresses upwards. So then it gets into the middle of the brain. And this wouldn't normally cause any more movement problems, but it does start causing other problems. So quite often there'll be early signs of emotional problems. There's also quite a lot of research that shows that the smell of a patient will be severely affected before they notice anything else. And then in the end stages of the disease, the cell loss is spread right throughout the brain. And this is where everyone used to find dementia. They're like, there's cell loss in these front bits, which are really important, and there's cell loss in here, which is also really important. And everyone went, oh yeah, well, I guess that's why we get dementia sometimes. So what I wanted to do was try and figure out what's going on in here before it gets this bad, and see if we can find areas of cell loss in here which predict the rate and progression to dementia. So as I said, we have a huge group of patients with Parkinson's disease that volunteer to be part of our study. We don't make them do it, they're quite happy to do it, I swear, if anyone's from the ethical committee here. We give them major cognitive testing, so that means they come and sit in a room with us for up to 2 hours. They have to do that in 2 sessions. Give them heaps of little tests, like read this to me, fill this out, remember all these words. Can you put this piece of paper on top of this other piece of paper? Can you tell me where you live? Do you remember your name? When were you born? What day is it today? Is it springtime still? And they just go, okay, that's fine, I can do that. So it's not supposed to be stressful for them, but I've partaken in some of those tests myself, and I'm pretty sure I've got dementia at the end of them. But they do it, and they do it happily. And then we give them the brain imaging. So we throw them in the big, noisy, horrible scanner, make them lie still, and we get lots of pretty pictures from that. So obviously such involved research can't be done alone. So this whole entire list of people here have all helped in some way, basically, even if it's just to make me coffee sometimes. And that's the beauty of the Brain Research Institute. We're a multidisciplinary team. We've got engineers, we've got physicists, we've got almost psychologists, we've got almost doctors who think they're real doctors. We've got all sorts going on there. And it's not government funded, so any donations are gratefully accepted. Our patients, though, are the most important thing. We couldn't do this without them. So, you may be wondering what all this time and money is actually doing. How is it useful to look at these brains of people? So if we're looking at our little MRI scan of a normal person and then looking at a normal Parkinson's disease person, this is someone in the mid-stage, so they've got a little bit more sort of gap here, but nothing major. And then this is our dementia patient, who things are a little bit all crammed up in here, but there's all this sort of missing cells in here. So dementia is only identifiable in the clinic after doing all of those millions of cognitive tests. It's hours and hours of testing, and then even then, it still takes a while to sort out whether someone has dementia or not. But there is new evidence, mainly from our group and a whole lot overseas. There's also a lab in Auckland that's doing a lot of stuff with this. So, and they've been able to test people who don't have dementia, and shown that people that have problems in only some areas present the greatest risk to dementia. So someone here in the mid-stage, for example, if they have problems with sustaining attention while we do all these millions of tests on them, or they only have problems with learning something new, those are the ones that present the greatest risk to dementia. So they're more likely to develop it within 2 or 3 years rather than never at all, or rather in 10 years. And so that's actually been quite useful for us. And now we've found this intermediate group of people, and we've been doing a lot of work with them. So the plan was to try and take pictures of these patients here, and then take pictures of different patients here, and then finally pictures of different patients here, and see what's happening. And what everyone in this situation does is just assume that there's any changes here represent what's happening between here and here. So it's the progression. Even though it's not the same people, it's different groups of people, we just generally assume that if there's suddenly more cell loss here than there was here, then that just represents an advancement of the disease. So what we've found is actually quite amazing, if I do say so myself. We didn't look at the whole brain. Everyone's done this before. We weren't interested in doing it again. Our group has previously done it, and our results match everyone else's, so it's just time to move on, really. We looked at the thalamus, which is this little structure right in the middle here. The thalamus is quite important. Turns out it's connected to everything. And turns out little bits of it are connected to little bits of the brain. So this flashing bit here, that's connected to the sensory field that helps you interpret stimuli and listen to things and see things. That's in the thalamus. This is another piece of the thalamus. This is connected to the frontal lobes. This helps with your behaviour and with your memory, and mostly with your inhibition. And according to what Nigel later says, the frontal lobes are the ones that aren't quite developed in teenage boys yet. So some of our Parkinson's patients sort of regress back to their teenage years, which can be hilarious for us, but quite problematic for their wives. This is another wee bit of the thalamus, also connected to the frontal areas, also involved in memory. This is a separate bit connected to your motor cortex, involved in movement. So this has nothing to do with memory, it just does all the moving stuff. And then this one's also involved in movement, but connected to an entirely different part of the brain that controls a different aspect of movement. So, what we found was that our lovely little red blob gets smaller when you've got dementia. It gets smaller compared to people that are normal. It gets smaller compared to people who have Parkinson's with no dementia, which is really important because that means it's not just the motor symptoms of Parkinson's that are causing it to get smaller. It's not the Parkinson's disease itself, it's the dementia, I think. I'll let you know what my reviewers think about that when I start proclaiming that wildly in my thesis. And it also gets smaller compared to our mid-stage people. So this isn't actually that amazing. It has been reported before in 4 other studies, but it's always nice to get on the bandwagon and just confirm what others have already told you. This is what is going to make me rich and famous. So, as well as measuring how big the thalamus was, we also measured what the little brain cells within it were doing. So we used quite complicated imaging, which basically just showed us if the cells were disrupted, or if they were degenerating, or if they'd fallen apart, or just really what they were up to. And we did it through measuring water. So if the water moves really fast through that area, that means that all the little cells are broken, and they're not trying to stop the water moving, just letting it go on through like the sea, and it's just rapidly moving through there. So that's what this graph is. These numbers represent how fast the water is moving. So you can think of if the water's moving fast, that's really bad because that means there's cell loss. And so in our dementia patients, the water is moving really fast. It's also moving quite fast in our mid-stage patients, and not as bad down here in our Parkinson's patients with no impairments. So the dementia group has cell damage that's greater compared to all other groups. So it's worse than every other group. And then, this is where things get interesting. This is what hasn't been seen before, and this is why we are awesome. The thalamus of the mid-stage people is also showing cell damage, and that's showing cell damage compared to the people with Parkinson's that don't have any memory problems, as well as compared to the normal control people. So the fact that there's damage here in our mid-stage group that's greater than just in our normal Parkinson's groups, again means it's due to their memory problems and their attention problems that's causing this. It's definitely not just the motor symptoms, although that will be contributing, but not as much. So that's all good and well to plot someone on a graph, but what does that actually mean for the daily life of the patient? So our mid-stage patients could be having movement problems, probably, considering they've got Parkinson's disease. They could be having memory problems. They could come home and not be able to find their keys. It might not be as great as that. They might just open the fridge and forget why they're there. Nothing major, normal everyday stuff. They could be having normal, just general cognitive problems. So just feeling slightly not, they're not quite coping. Normally there's problems with planning, there's problems getting somewhere on time, and there's problems taking the right people when you need to go and do that. Sometimes there's behaviour problems, not always, hardly ever in the mid-stages. There's also been quite a lot of research on pain processing in Parkinson's, so they're acutely sensitive to pain, much more than a normal person. Quite unfortunate we've only just figured this out now, but sorry about that. Sometimes there's emotional regulation problems as well, so just getting upset when you wouldn't normally, or being really happy when maybe it's not appropriate. And that's because the thalamus is connected to all of the bits of brain that control all of these things. So, the question has been asked, if everyone that has thalamus problems shows the same symptoms, so do you and your neighbour next door, you've both got thalamus problems, do you have the same problems with your memory, do you think? Do you have the same problems with your attention? And I've got a really good analogy to answer this question, because I had to explain this to my mum once. So in February, this happened. Huge earthquake, you might have heard about it. And the hospital ended up being evacuated. And because of where our clinic is, we were in the cordon for a good couple of weeks. And our servers went down, and all my data was in the cordon, and my house was also in the cordon. So I was stuck out of home, out of work, with no data at all, trying to finish my thesis. It wasn't stressful at all. It's completely fine. I have a whole degree in psychology. I definitely handled it just fine. And I was slightly stressed about it, and complaining to my mum on the phone that this was getting ridiculous and my thesis was going to take forever now, because I didn't know where my data was. I didn't know whether it was okay or not. I didn't know, even if I'd be able to continue. And she came out with this. She was like, "But darling, you've looked at all the scans. You know who has a thalamus already." I was like, "Oh, okay." Unfortunately, it's not actually that simple. You may have thalamic degeneration. You may not have a thalamus, maybe. But that doesn't necessarily mean that you're showing the same symptoms as the next person who also may have bits of their thalamus missing. So some of our patients will have executive function deficits, so trouble organising and planning. Some of them will be fine at that, but instead they'll have memory problems. We'll be like, "Here, remember this list of 12 words?" And then 5 minutes later we'll be like, "What were those 12 words?" And they'll go, What words, dear? What are you talking about? There was no words. Don't be ridiculous. You didn't give me any words. And then some of them will be fine with both of those things, but they won't be able to draw a cube on a piece of paper. And that's because their eyes are having trouble interpreting what the cube actually is on the piece of paper, and has even more trouble recreating it. And then add to this all the connections between our little thalamus and the rest of the brain, and we actually have quite a huge opportunity for variation in problems. So this is the fat controller. He's quite helpful in explaining my thalamus to people. So what I tend to do is think of the thalamus like the fat controller. It's the big blob, it's in the middle, It's just hanging out, just controls everything, literally everything. So you can think of the wee tracks that connect the thalamus to the rest of the brain as train tracks. And the thalamus is sitting there, putting out the information where it needs to go in the right trains. As well as doing that, it's taking information from the outside world and taking it into the thalamus in a different train. Unfortunately, there's not just one train track, there's hundreds of them. These are just the main big ones, but every little piece of the thalamus has a little associated train track that goes out, and one that goes in, and one that goes off to the side, just for fun. And then there's little train tracks within the thalamus that connect each other. So in the station, there's lots of little tracks as well. And basically what happens is, in a normal person, the trains are running just fine. The information's coming in, the information's going out, the train tracks are just sweet as, and the fat controller's got this happy expression on his face. In the late stages of Parkinson's disease, things start to go horribly wrong. Some of the trains, the information's not going out. Sometimes it's not coming in. Sometimes it's coming in and getting misinterpreted and just getting stuck. And the fat controller's not really that happy about that. So because it's such a complicated little structure and the little bits do different things, we decided to use even more technically crazy, colourful imaging to break it into tiny little pieces. And we thought, okay, if the whole thing shows cell damage, let's just see whether that's consistent across the whole thing or whether some bits are worse than others. And so this Technicolor amazement is each of the bits of the thalamus. So each colour is a different nucleus, and each nucleus does a different thing. Not surprisingly, what we found was that different nuclei are involved in different symptoms of Parkinson's. And also, where it gets interesting is, they degenerate at different times. So the frontal ones are normally the first to show any problems. And the reason this is important is because some of the first symptoms of Parkinson's disease are normally frontal. So they're involved in the frontal lobes, and apparently now also, turns out, they're involved in the anterior or the frontal nuclei. So each of these blobs here are the blobs of the thalamus that are most involved in the different aspects of cognition. And what we aimed to do was to use the information about their cell structure to try and find those people in our Parkinson's patients who didn't have any dementia yet, to try and find the ones that were showing the earliest symptoms. So the ones that had, just for example, attention problems, we thought, hey, let's look at your frontal bits of your thalamus and see if there's cells breaking up there. And let's see if that's related to attention. And the important thing to remember is that imaging is a much better sort of idea of what's going on. Like, it's all very well to sit someone down in a room for 3 hours and measure their attention, but there's lots of variation there, which is why we see them all the time, once a year. Lovely people. So what we aimed to do was get the images that give us a better idea of the problems that are there before maybe a clinician could pick them up using lots of little tests. And so in our patients who only have Parkinson's disease, they do show some level of degeneration in the front nuclei. And what we think will happen later is, if we bring them back in a couple of years, maybe 2 years, maybe 5 years, maybe all of the above, that they'll begin to show the cognitive symptoms, so the memory problems and the attention problems that relate to that area of the thalamus. So they're not showing them now. These people on paper are completely fine, but the front pieces of their brain are showing some decent cell loss. And that's not recognisable in the clinic yet. So we've found it well before that a doctor or a clinician can pick it up. So the question may be asked, if it's just the thalamus that's causing all these problems, oh, the rest of my brain's fine, it's just my thalamus. It's not exactly how it works, but the thalamus does seem to be the beginning of the problems, because remember, things start down here with the motor symptoms, and then they get here, and at this stage, patients are still normal. They don't have any dementia yet, they don't have any problems yet. But what we've shown is they're not that normal. They are showing the beginning of problems, and we really want to get onto this before they get to dementia. And we go, oh yeah, turns out you weren't that normal after all. Whoopsies. that's not really good enough. So we're going to start doing much more investigation at this level before patients get to this level. No one wants all these red bits in their brain. It's a terrible idea. But because the thalamus is connected to everything, we had to investigate all the tracks, all the little train tracks, every single one of them, multiple times for each patient, on both sides. And that didn't take very long at all. So this is a normal brain cell, and all these little bits are all the train tracks. The main ones we were looking at is just the axon, so it's like the main communicating train track. And this is what they look like in the thalamus. This is a heavily thresholded image. So it may look like there's just one track going from the thalamus out to the frontal lobes here. There's not. There's hundreds of them. I've just, for ease of simplicity, just shown one, the strongest one. And what happens is, in our normal people and our Parkinson's people with no memory problems yet, they basically look exactly the same. There's no cell loss in any of the bits of the thalamus, and all the little train tracks are fine. They're basically not showing any issues at all, apart from right here, this little white bit. You can think of the white bits like decay. Decay is bad. In this case, the white bits are bad. This means that there's some cell loss happening here. So remember, these people are normal. They don't have any memory problems. The clinicians told them they're completely fine. No problems at all, but they are showing quite significant cell loss in the areas that are known to cause the earliest symptoms. Our mid-stage people, all their little train tracks are still completely fine, but their thalamus, or their fat controller, that's beginning to show cell loss in other areas. So here's the wee front bit that's broken over here as well, and then some of these middle bits in here are also showing a decent degree of cell loss, and then down here too. Dementia, this is where things begin to go seriously pear-shaped. There's major cell loss in the bits of the thalamus, but this isn't a surprise to us. We knew that. People have told us this before. People have told us that the cell loss is so bad that the thalamus actually begins to shrink. And we've just confirmed that. So there's basically cell loss in every area once dementia has developed. Interestingly though, the tracks are fine here and here and here. So while the thalamus is degenerating in those in the mid-stage, the tracks are still fine. But over here, the tracks are all degenerating as well. And this is relatively new. It's been seen in Alzheimer's disease, but not in dementia with Parkinson's type yet. So it just means that as well as the fat controller and the station being all lost and confused, all the trains are also all lost and confused. So I guess the crux of the issue is, why is this even important? Who cares about our train tracks and our thalamus and our fat controller and Thomas the Tank Engine? And what we tried to do was to present the world with something that they can use to predict Parkinson's disease dementia in patients who otherwise appear normal. And so there's this complicated statistical way of doing this. If we just look at this, where 100% is perfect, 0% is obviously not, what we've been able to do is, using our cell loss measures, is show how accurately we can identify the brains of a patient with Parkinson's disease dementia compared to a normal control person. So we can take the image of a dementia patient and take the image of a control person and be like, right, give me some idea of how accurately, tell me how accurately you can tell me whether this patient has dementia or not. And so these are just the pieces of the thalamus, but basically the line is between 60 and 80%. So 60 to 80% ability to look at the image of the dementia patient and say, oh, yep, you've got Parkinson's disease dementia. Great. Because obviously we know from our patient sample who already has dementia, all we've done is taken their images and thrown it in the computer and to figure out whether the computer knows. So we've got pretty decent accuracy in finding the dementia patients, but as I've said, it's pretty obvious when someone has dementia. That's not that useful. The cutting edge science of it is that we can also use the thalamus to predict who's in the mid-stage. So who in the clinic is appearing basically fine, but obviously has some major cell loss. And we can predict that between 55 to 70% accuracy. And then where it's even more important is if you've got a patient with no dementia and you've got a patient with dementia, they've both got Parkinson's disease, but we want to tell, just by looking at their images, what their cognition's up to. And we can predict that with around 80 to 86% accuracy as well. Between the patients who have normal cognition and the ones who are in that mild stage, we can predict that with around about 70% accuracy using our measures of cell loss in the thalamus. And that's where it's more important, because the mild stage is not easy to pick up in the clinic. Quite often patients won't even realise they're having problems. It isn't until their wives start nagging louder than usual and more frequently that they realise they actually are having major problems. And by then, by the time they're in our clinic, they're already quite advanced. So this, theoretically, could be used to take a patient, scan him, and then figure out where he's at before he's gets over his Kiwi maleness of telling you that he doesn't have a problem. I'm fine, dear. It doesn't matter that I can't remember those words. They're not important words. Why would I need to remember them? So this will tell us, without any rubbish, thank you very much, Mr. Patient, and without any confusion, with 70% accuracy. Predicting between the ones in the mid stage and the end stage isn't as easy. It's quite variable depending on which bit of the thalamus you're looking at, but we can still get there between 70 and 80% of the time. To put this into context, you might be thinking, oh, 70%, who cares? That's not awesome, that's not 100%, I wouldn't be putting money on that horse. But when you go and get a mammogram, it's only 76% accuracy of detecting cancer. And most of our bits of the thalamus are giving us higher accuracy than that between some of the groups that have historically been really, really hard to identify. And so this is our next step. These aren't my pretty images. These are Dr. Tracy Melzer's pretty images. He's amazing. And he started following up some of our initial patients. So these guys are at 2-year follow-up. So they came into our clinic 2 years ago and they had a scan, and now they've come back 2 years later and had another scan. These little colours are all the changes that have happened in those 2 years. So these bits here are the train tracks. So this train track is changing, it's getting worse. In here the train tracks are changing. Down here they're changing. This is only 2 years, this is happening quite fast for these patients. And then this is their blood flow. So if your blood flow starts changing, that means that your brain underneath the blood flow is also changing. It's just one of the tools that we use. And all these blue areas are showing pieces that have changed in the same patients just over that 2 years. So ideally, once we've got a decent map of all the changes that happen from time 1 to time 2, and then I'm sure all these guys will come back for their 4-year follow-up and their 6-year follow-up and their 22-year follow-up. Once we've got some idea of what they're doing, hopefully we can intervene when someone invents something amazing and stop all of this happening, or at least slow it down so patients have a better chance of quality of life. But remember that they're not all going to end up with dementia. And we don't even know whether these people are going to have dementia yet. Some of them are just still patients with no cognitive impairment. So I think all the interesting data will come out in about 8 to 10 years of the ones that do develop dementia. So, in a nutshell, we've shown what others have already shown. Thalamus changes in Parkinson's disease. It gets a bit smaller. But we've also found what others haven't. At the level of the brain cells, there's major disruption there, and that's evidenced by our crazy MRI methodology. And the crazy disruption is evident well before dementia is. So a patient can be appearing completely normal in the clinic, sitting there remembering all the words, doing all the things, and they've still potentially got quite a severe disruption in the thalamus. But remember what my mum said, not everyone will have that level of disruption. It's variable per patient. Some of them will have it badly in some areas and be completely fine in others. Some of it will have it badly in one area and be fine in a different area. Some of them will have no changes at all. They'll just keep soldiering on, pretending like they don't even have Parkinson's disease. And the degeneration relates to the cognitive symptoms. So in the front bits of the thalamus, that relates to what we commonly call frontal symptoms of attention and functioning and planning and organisation, all of those things. This all happens before the tract degeneration. So cell loss is evidenced in the thalamus before the train tracks start falling apart. This has been shown before in people with brain injury, but not ever in Parkinson's disease. And all of this can be combined into one handy little graph and helped to identify those with dementia. So theoretically, in a few years, if we ever get onto this, someone could come in and just have a brain scan and get that matched with all their interviews and all their tests that they have to do, and that'll give us a much better look at who has dementia, who might develop dementia, and what's going on. So there's a massive potential there to use this method to follow the patients throughout the disease. So if they come in their first year of diagnosis and come in at 5 years and at 10 years and 15 years, we can see what's happening, and then one day someone will invent something that can actually help them. So the intervention is really where we're headed with this. I'm not, personally. I've finished my PhD. I'm going to get out of here. But someone else, somewhere, will do something about this. And hopefully now they can use this as their tool to do it.